Good morning, everyone. Today I'll try to explain and learn something about myoclonus and its application in psychiatry. So let's start by learning what myoclonus is. Myoclonus is defined as a sudden brief shock-like involuntary movement caused by muscular contractions or inhibitions. Contractions produce positive myoclonus, whereas inhibition of ongoing muscle contractions produce negative myoclonus. An example of that is asterixis. And patients will usually describe myoclonus as jerks, shakes, or spasms. Now, it is distinguished from tics, chorea, and jerk dystonias by the absence, for example, so let's start with the classification. The first attempt to classify myoclonus was in 1903 by Lundborg. He classified into three groups: essential myoclonus, symptomatic myoclonus, and yes. Myoclonus, it has to be clinically differentiated from other movement disorders, which are jerky, such as tics, chorea, and jerk dystonia, often called as dystonic myoclonus. We distinguish myoclonus from tics by the absence of the urge to perform in movement, lack of suppressibility, or relief of tension following the movement, which is typical in tics. The repetitive nature of cortical myoclonus in the fingers can also sometimes resemble tremors. We'll learn about the classification. It was classically classified into three groups: essential, symptomatic, and familial myoclonic epilepsy. However, currently we classify it according to its anatomical distribution, relation to activity, precipitating factors determined on examination, neurophysiology, and etiology. Based on body distribution, we can divide myoclonus into focal, multifocal, segmental, and generalized. And based on relation to activity, it can be differentiated as myoclonus occurring at rest, during an action, or posture. There is also a neurophysiological classification which focuses on the pathophysiological generation of myoclonus and the mechanism of propagation regardless of the clinical presentation. Since a single disease can have myoclonus caused by different mechanism, we have to, along with the clinical presentation, we have to try to determine the neurophysiological cause, as this helps us to decide in getting the most effective treatment for the patient. Because, for example, drugs effective in cortical myoclonus may not be effective in other type of myoclonus. So the physiological categories of myoclonus include cortical, cortical subcortical, or subcortical non-segmental, which includes brainstem reticular reflex myoclonus, hyperechoplexia, and propiospinal myoclonus, segmental myoclonus, and peripheral myoclonus. Cortical myoclonus is the most common form of myoclonus we'll encounter in our clinical practice. Cortical myoclonus mainly affects the distal upper limbs and face, reflecting the largest cortical representation of these body areas. It is mainly present during action and is often induced by somatosensory and less often visual or auditory stimuli. Most patients will have positive and negative symptoms, which occur either independently of each other or together as a complex. Typical example of cortical myoclonus are Alzheimer's disease, Creutzfeldt-Jakob disease, corticobasal syndrome, dementia with Lewy bodies, some viral infections, metabolic encephalopathies, and lithium intoxication. Now, cortical subcortical myoclonus, it refers to myoclonus arising from the paroxysmal above excessive oscillation and reciprocal connection between cortical and subcortical sites, particularly the thalamus. The physiology is characteristic of epilepsy syndrome, such as juvenile myoclonic epilepsy and myoclonus with absence of epilepsy. These jerks are typically generalized, but focal or multiple focal jerks can also occur. Now, subcortical non-segmental myoclonus. The clinical and neurophysiological features of these subtypes are more variable than the previous two due to multiple possible subcortical sites. Two major clinical patterns are observed: myoclonus from a localized source, which includes brainstem reticular reflex myoclonus, startle as well as startle syndromes, and propiospinal myoclonus, and multifocal myoclonus in hereditary essential myoclonus. So in this slide, this is an example of propiospinal myoclonus. Brainstem reticular reflex myoclonus is generated from low brainstem reticular formation in the medulla. It's presented with generalized synchronous jerk that predominantly involve axial and proximal flexor muscles of the limbs. These jerks are present at rest and aggravated by voluntary movement. So in this case, we see when we ask the patient to move, the jerks get worse. The most striking clinical feature is sensitivity to multisensory stimuli, particularly auditory. This is seen in hypoxic encephalopathy, uremia, viral encephalitis, and demyelinating neoplastic or vascular lesions of the brainstem. Now, startle. Startle is a physiological brainstem reflex, which is defined as abrupt, involuntary, rapid body jerking and unexpected stimulus. So, when we get scared, we get startled. It's present in normal, healthy individuals starting from the 6 weeks of age, and it persists throughout life. Clinically, it begins with blink and facial grimacing, followed by synchronous inflection of the neck, trunk, elbows, knees, abduction and flexion of the shoulder, and pronation of forearms, followed by a period of decreased activity, and then a late voluntary behavior such as anger or disgust, and an autonomic response that lasts for approximately more than 3 to 10 seconds. When the startle is abnormal, exaggerated, and doesn't habituate to repetitive stimuli, then it's called startle syndrome. This can occur as a manifestation in other disorders such as startle epilepsy, stiff person syndrome, strychnine poisoning, or as a part of neuropsychiatric syndromes such as LATA, jump entrenchment, anxiety disorders, and Tourette syndrome. And now we'll talk about hereditary essential myoclonus. It's an autosomal dominant disorder which is believed to be due to mutation in the SGCE gene on chromosome 7q21. It is classically inherited from the father because of maternal genomic imprinting. And major features include lightning-like multifocal action-induced myoclonic jerks involving the upper extremity, neck, and trunk, which are always present spontaneously. So in the on the bottom right, we can see the jerks in the trunk. Segmental myoclonus, on the other hand, gives the jerks a focal or a circumscribed description. It is unaffected by the supraspinal influences like state of consciousness, as it will persist in sleep, voluntary action, and sensory stimulus. And palatal myoclonus, now called palatal tremor, is the most common type, followed by spinal segmental myoclonus. We can see this is palatal myoclonus, now palatal tremor. We see slow rhythmic contraction of the soft palate, sometimes synchronously affecting the muscle of the eye, face, tongue, larynx, and even trunk and intercostal muscles. There are two types of palatal tremor, essential and symptomatic palatal tremor. Spinal segmental myoclonus, however, is confined to muscles innervated by one or the few contagious spinal segments. Jerks are rhythmic or semi-rhythmic, spontaneous, and are occasionally stimulus sensitive. And in the end, we see peripheral myoclonus. It is characterized by rhythmic or semi-rhythmic focal jerks due to lesion in the nerve plexus, due to a lesion in the nerve plexus or root. Best example is a hemifacial spasms we can see in the GIF. Central relay mechanisms play a significant role in addition to ectopic excitation and haptic transmission from the nerve. We can also classify myoclonus on the basis of etiology, and the main categories under that are physiological myoclonus, essential myoclonus, epileptic myoclonus, symptomatic, and psychogenic myoclonus. Physiological myoclonus refers to jerks which are occurring in healthy people. So examples of physiological myoclonus are simple things such as hypnic jerks, hiccups. We'll see physiological myoclonus after exercise. They can be due to anxiety, just a simple startle response, as we've discussed, or benign infantile myoclonus with fever. Now, in essential myoclonus, it's either the most prominent or the only symptom, and this clinical presentation is usually chronic and follows a stable course over time with minimal or no disability. Epileptic myoclonus refers to condition in which myoclonus occurs in the setting of epilepsy. It can occur as one component of the seizure, or it can occur as one of the multiple seizure types with an epileptic syndrome. The most common example of this case is juvenile myoclonic epilepsy. And symptomatic myoclonus is the most common etiological type of myoclonus. It occurs in the context of an underlying medical or neurological illness. It's commonly accompanied by other manifestations such as seizures, encephalopathies, ataxia, Parkinsonism, cognitive impairment, spasticity, or peripheral neuropathy. And the final one is psychogenic myoclonus. It can occur spontaneously or following an external trauma. Characteristic features include sudden onset and remission, constantly changing anatomical and temporal patterns, distractibility, variable amplitude, inconsistency over time, and placebo response. This can also be focal, segmental, multifocal, or generalized, and it's aggravated by stress and anxiety. There is exaggerated stimulus sensitivity to visual or auditory stimuli. Despite these characteristics, it is sometimes very difficult to differentiate psychogenic from organic myoclonus, and we need to do an EEG, EMG polygraphy to help us differentiate between them. So how do we evaluate patients with myoclonus? We have to do it in a basic three-step approach. We take history and examination with the determination of the clinical classification. We'll do some basic laboratory testing. And the final step is neurophysiological testing. Now, treatment. The most important factor in the management of myoclonus is the treatment of the underlying etiology. However, symptomatic treatment is usually required as treatment of the underlying disorder is insufficient in the majority of the cases. As we saw, most of the reasons for myoclonus are due to spinal lesions and nerve injuries, and we cannot really treat those. So the best strategy for symptomatic treatment is to define the physiological classification with the help of neurophysiological tests. And the drugs that work, so I've already used this example of drugs working in cortical myoclonus, work in most cases and will be tried first as it is the most common type of myoclonus. So what are the drugs that we use? For cortical myoclonus, usually a combination of drugs are required. The four most effective agents are levetiracetam, piracetam, valproic acid, and clonazepam. And the first line agents are levetiracetam and valproic acid. For subcortical myoclonus, the drug of choice for this subtype is valproic acid, as the most common example of this is juvenile myoclonic epilepsy. The therapeutic dose range is 500 to 2000 milligrams daily in 2 to 3 divided doses. And if it is not effective, we can use levetiracetam and lamotrigine. Sir, used sir, एक तो journal में से sir I've used a review and I've used the Adams and Victor neurology test.
2000 milligrams 2-3 times. So actually, Valpert is given in milligrams per kg.
Subcortical non-segmental myoclonus, standard anti-epileptic drugs will not be effective in most of these cases. Still, clonazepam is the first choice in most subtypes. Zonisamide 100-300 milligrams a day, sodium oxybate and anticholinergics can be used as alternative agents for myoclonus dystonia. If it's medication refractory, we can give bilateral palladial deep brain stimulations. For segmental myoclonus, so for palatal tremor, the treatment is very difficult and many drugs have been tried with limited success. Botulinum toxin has been proven to be safe and effective, but again, it is difficult to inject. Surgical procedures such as tensor belly palatini tenotomy and eustachian tube occlusion can be considered for disabling ear click. For spinal segmental myoclonus, the drug of choice for this subtype is also clonazepam, but complete suppression is uncommon. And we can also use botulinum toxins for alleviating pain and movements of spinal segmental myoclonus. And for peripheral myoclonus, both clonic movements and tonic spasm of hemifacial spasm respond excellently to botulinum toxin injection. Medications such as carbamazepine and gabapentin can be tried but have limited. These are the references.
Good morning, everyone. Myself, Dr. Kunal Sharma. I'm going to present a presentation on GI bleeding and mental health. And my moderator is Dr. Tanya. So I'm comfortable like this. So GI bleeding. What is GI bleeding? GI bleeding is blood loss from within the gastrointestinal tract, and it can be upper GI bleed and lower GI bleed. There is ligament of the treats at the duodenal flexure. Proximal to it, it's if bleeding is occurring, then it's upper GI bleed, and distal to it, if bleeding occurring, then it is lower GI bleed. And acute small bowel bleeding is rare. Some common causes and risk factors of the GI bleeding are for upper GI tract, gastric or duodenal ulcers, varices, Mallory-Weiss tears, and gastrointestinal stromal tumors. For lower GI tract, anal fissures, hemorrhoids, colonic carcinoma, and colonic polyps. Some medications like NSAIDs can also cause ulcers, which will further lead to bleeding, and bisphosphonates, which can lead to esophagitis. And malignancies, some fibril tumors can bleed out, and alcohol can lead to the alcohol-related liver diseases, which can further lead to portal hypertension and esophageal varices. Patient with severe mental illness are on selective serotonin reuptake inhibitors, which can lead to bleeding of both upper and lower GI tracts. Diagnostic principles. First, we have to exclude the upper GI bleed because it is mostly fatal. So first we rule out the upper GI bleeding. After that, we go to the lower GI. Signs of upper GI bleeding: hematemesis, coffee ground vomitus, and melena. Signs of lower GI bleeding: hematochezia and hemorrhoids. In hematochezia, if there is large upper GI bleeds, then it can also present as hematochezia. Investigations. We will first put ECG, cause due to due to blood loss, there can be the cardiac ischemia. So ECG will be really helpful, and we will go for blood investigations, full blood count, urea and electrolyte, clotting factor screening, liver function test, iron studies in chronic GI blood loss, and blood cultures for liver diseases and infections. Management. If patient is inpatient, then patient is kept nil per oral until the endoscopy decision is made. And if there is frank bleeding and hemodynamic instability, the patient should be transferred to the medical unit and ensure the following: secure their airway, check airways patent and secure, and gain intravenous access to IV large bore cannula. And if blood pressure is low, then commence the fluid resuscitation by 0.9% NaCl. And if patient is hemodynamically stable, then and there is no sign of bleeding, then we should calculate the Blatchford score. If there is low risk Blatchford score, that is 0, then the patient is non-urgent and can be managed in outpatient. And if high risk scores are present, then the patient is classified under the urgent, and endoscopy should be done within the 24 hours inpatient. So what is the relation between the GI bleeding and the psychiatry? In the psychiatry, we commonly use the SSRI, selective serotonin reuptake inhibitors, which inhibit the function of the platelet, which can lead to the upper and lower GI bleeding. And in chronic alcoholics, alcoholic liver diseases are most common, and that will lead to further cirrhosis and portal hypertension and esophageal varices. And IV drug users abuse syringes and share them, which can lead to STDs and viral hepatitis, which will further leads to cirrhosis or liver dysfunction, which can interfere with the clotting factors formation. That will also lead to bleeding. And eating disorders, example bulimia, will lead to frequent vomiting, and this will cause the Mallory beast here in lower GI, lower esophagus. Thank you.
If there are any questions, queries from anyone regarding both of these topics? Comment from anyone? Endoscopy, you did not say in assessment, initial assessment, you said and all. Endoscopy is one of the, not only
Diagnostic and
intervention. What is the contraindication? Endoscopy. There is a condition, there is a strict condition of corrosive substance corporation. Although careful assessment, even in that case, can in certain cases drastic change. Palpable dose, how do you what is it for palpable seizures? How do we do that? And also we have serum valproate levels. So you, because depends upon metabolism. So for individual we can, earlier it was very costly, but now we do the serum valproate levels for individuals, and we can assess the that. Frequency can be like valproate has different preparations. Okay, valproic acid, and there is divalproate, and there are extended release. So that can be given once daily also. Clonazepam has a good role in myoclonus. Drug-induced myoclonus is not frequently disconnected. So antipsychotics are okay. Hello. Morning. हाँ जी, नहीं पर यह है कि भाई कल हो गई आज हाँ ट्यूसडे को हाँ हाँ ठीक है या ड्रग इंड्यूस्ड एक्सरसाइज में भी तो एक्सरसाइज में माइक्रोनस जिटरीनेस होता है माइक्रोनस बहुत कॉमन होता है पेशेंट्स रिपोर्ट करते हैं कि लिम्फ फिक्स करता है और जो है कहते हैं हाई डोज में जैसे ओसीटी वगैरह में ठीक है डिफरेंशियल जैसे पीएलएमएस है पीरियोडिक मूवमेंट तो आईएलएस के साथ में तो वी हैव टू डिफरेंशिएट दैट फ्रॉम माइक्रोनिक ड्रग्स राइट माइक्रोनिक एपिलेप्सी that we have to differentiate. So, carbamazepine can cause myoclonus. EPS से differentiate करना होगा. Okay. If the surgery is tomorrow and the patient is already on exercise, देखो usually dictum वही 24-40 hours पहले हम पोर्ट कर देते हैं, है ना? और फिर जो है वो रीस्टार्ट करते हैं, पर ऐसा कोई एब्सोल्यूट कॉन्ट्राइंडिकेशन कहीं पे कोई ऐसा एब्सोल्यूट लाइक पर्सन ऑन SSRI even on elective surgery cannot go for surgery. It is not that okay, relative है, but now in the guidelines it is not prescribed that we should. Like if a person is being posted for surgery, we should stop at SSRI. Risk है पर इतना ज़्यादा नहीं. That's it. For the safe side, you can 24 to 48 hours before you can stop. And these are that is for psychotherapy. ज़्यादा तो वो जैसे मतलब most more patients are on you can say aspirin like compared to aspirin the surgeries are very low and aspirin the 4-5 days is prescribed then there are NSAIDs okay so they also have that bleeding problem in context of the list of drugs that produce that bleeding so SSRIs are there but they are lower on the list. Still to be on the safe side, although I'm doubtful if whether 2 or 3 days the effect will go. Psychogenic myoclonus is dissociative. It is a type of dissociative. एक psychogenic टर्म अब हम कम यूज करते हैं जो है उसमें इसलिए फंक्शनल लॉजिकल सिम्पटम्स बट साइकोजेनिक बोलो डिसोसिएटिव बोलो फंक्शनल बोलो इट इज नॉट सीजर so it is a type of dissociative जो डिफरेंशिएट करने में दिक्कत आती है कि फंक्शनल और माइक्रोनस में एक सिमिलर चेंज जाता है, पोटेंशियल होता है, चेंज कर सकता है जगह से स्टेबिलिटी होती है। यूजुअली माइक्रोनस पेशेंट तुमको सामने भी देखेगा पर वो करते नहीं है। कई लोगों को जैसे टेक्निक से, पर कई लोगों को ये होता है ना, ज़्यादा वो नहीं है। ठीक है, थैंक यू बोथ ऑफ यू डिड वेरी वेल, presented well. You should जैसे रेफरेंसेस के दूसरे टेस्ट आरसी में क्या दिया है माइक्रोनस के लिए, उसमें है ना सीजर्स के लिए फर्स्ट लाइन सेकंड लाइन देखा तुमने? आई एम डाउटफुल इफ पैरासिटामोल इज फर्स्ट लाइन थेरेपी फॉर माइक्रोनस। चेक if पैरासिटामोल is okay, पैरासिटामोल is actually a different class of ठीक है, ओके। कितने पेशेंट्स? चलो यहाँ पे देख लेते हैं फटाफट से।
अच्छा